again, thank you all to the speakers, our industry colleagues, and everyone for supporting the program. It's really a great pleasure to have you here. So this is a new talk for me, brand new. You're the first people to hear it. I've actually never given a talk on this topic, but I thought that I would sort of branch off into a somewhat different arm of the trauma world, which is what I usually talk about, and touch on this area. You know, there's a subset of consults that those of us who've been in practice for a long time, like, don't really want to get. You know, bad priapism, bad hemorrhagic cystitis in a radiation patient, and something bad is happening in a pregnant patient. I think this is on the list of some of the most troublesome and really, in a sense, frightening consults. So I thought I'd work through this whole area of the urologic emergencies that come up in pregnancy and try to maybe give us a sketch of how we have approached some of them. Obviously, it's a broad topic and we can't touch on everything. So I'll touch on these areas. The key clinical concerns would be just a very brief comment on the physiology of pregnancy as it affects urologic status. Ureteral obstruction, either from stone or hydronephrosis of pregnancy. Iatrogenic injury, obviously this is one of the areas that we have to be prepared to deal with if we're consulted. Placental anomalies, and I'll talk in some detail about that because we have a very well-organized referral program at Texas Children's Hospital, which attracts, I'd say, the majority of the placental anomaly patients in the region. We have a lot of experience with it. And then just a brief comment on minimally invasive approaches to intervention and a comment on some of the challenging legal issues that we deal with when dealing with some of these iatrogenic injuries. So Texas Children's, you're probably all familiar with. It's been in the Texas Medical Center since the 50s, has a pavilion for women. It's TCH is the largest freestanding pediatric hospital in the country. Almost 9,000 patient visits a day, 3 million encounters of various types per year, very highly ranked hospital. And they built the Pavilion for Women about 10 or 12 years ago to have a major referral center for obstetrical and gynecologic care. It has a comprehensive high-risk birth center, a fetal surgery center, over 100 patient beds now, probably closer to 130. Is now doing over 6,000 deliveries per year, and it has a very well-organized placenta accreta spectrum program, which has a very broad regional referral base. In 2019, we did 42 cases. This year, we're 35, 38, and counting, so it's a big experience. I mean, a week doesn't go by when we're not dealing with an accreta patient. To touch on some of the relevant physiological factors, and I hope this will be useful to the residents, maybe when you're getting ready to study for your boards or your in-service exam, but these are things that, you know, they are pretty well-established principles. Physiological hydronephrosis of pregnancy is a well-known phenomenon, particularly on the right side. Over 2/3 of patients by third trimester will have this, and it's related to, you know, specific anatomical features, mainly proximal to the pelvic brim. The collecting system capacity increases substantially during the latter portion of pregnancy. There are changes that relate to increase in sodium, calcium, uric acid that affect stone formation propensity, but there are also changes physiologically that may produce some stone inhibition. So in the balance, when you really peruse the literature on the topic, there is no clear evidence that the actual incidence of stones in pregnancy is higher than in the female population in the non-pregnant state. But there are some definite clinical impacts, such as early incrustation of stents and nephrostomy tubes, which we're all very familiar with, and increase in this area is probably largely due to stasis and increase in urinary calcium excretion. This review article that I listed here on the slide from the Canadian Urological Association is a really good review on the topic of stones in pregnancy. Stones in pregnancy are the most common surgical indication in pregnant patients. The principles that we try to follow are postponing elective surgery until after delivery, obviously whenever feasible, certainly trying to avoid general anesthetic and intervention surgically during the first trimester. And there are very specific ACOG guidelines that describe what the priorities should be. I think it's very important to involve the OB service anytime you're taking a pregnant patient to the operating room, both to plan monitoring and to just seek their counsel because they are the experts on the medical management of the pregnant patient. And then ideally, performing any such procedure in a center with neonatology capability. This is the impact incidence of stone formation in pregnancy. Patients who develop symptomatic stones in pregnancy have increased risk of preterm birth, low birth weight, preeclampsia, C-section, premature rupture of membranes, and preterm delivery. So it is a clinically impactful event when it occurs. And there are challenges, obviously, diagnostically in distinguishing stones from just hydronephrosis of pregnancy. The AUA, the EAU, the American College of Radiology all have guidelines for imaging. Obviously, imaging is a delicate subject in the pregnant patient because of concern about radiation exposure. First-line imaging should be ultrasound whenever possible, but of course, ultrasound in this setting has relatively low sensitivity for actually showing the presence of a ureteral stone, but there are clues, and particularly the loss of the ureteral jet in addition to the hydronephrosis is a clue. The radiation dose of just a single KUB, some of us prefer to get a KUB even relatively early, hopefully after the first trimester, to look for a stone. But certainly an attempt at conservative management of stones that are obstructing in the ureter is clinically appropriate unless there's a clear indication to intervene, such as infection and fever. A lower ureteral stone during pregnancy of less than a centimeter in diameter has upwards of a 75% chance of passing. So putting a patient in the hospital, hydrating them, providing analgesia, and trying to get it to pass is a very sound approach. On the other hand, the stone that's obstructing at the UPJ and is seen there on ultrasound has a much lower chance of passing, so the likelihood of waiting that out successfully is significantly lower. The use of alpha blockers, tamsulosin or others, is controversial in the pregnant patient. There is substantial literature suggesting that it may be risky. I certainly wouldn't give it without the input of the obstetrician. And my feeling is that it's generally best to avoid alpha blockers. There have been a couple of cases reported of fetal demise in patients who were given alpha blockers, so you need to think very carefully about it. Obviously, temporizing with a ureteral stent or a percutaneous nephrostomy would be the standard approach if we do need to intervene. But of course, we do have a relatively high risk of bacterial colonization and encrustation. These tubes may need to be changed every 4 to 6 weeks, depending on how quickly they encrust. And there's a really interesting emerging literature on ureteroscopy for distal ureteral stones in the pregnant patient. I'd be really interested to hear Rick or others' comments about this. But the safety data on the series that have been published are actually quite favorable for distal stones, possibly a slight increase in preterm labor and C-section, but worth considering when you consider the likelihood of having to go in and change a stent every 6 weeks for the remainder of a pregnancy. The appeal of being able to do a simple ureteroscopy, pulverize a stone, put up the stent, take it out a week later, and then you're done can be very appealing. So worth considering, but it's a complicated set of decisions. S-wall is strictly contraindicated, mainly due to animal studies, but I don't think anybody would try it. It's contraindicated. And PCNL is challenging and largely contraindicated as well. Okay. UTIs. Asymptomatic bacteriuria in about 2 to 15% of pregnancies is noted. Lower tract UTIs have a 20 to 30% likelihood of resulting in acute pyelonephritis, and acute pyelonephritis is a leading cause of hospitalization during pregnancy. So the standard of care still is to treat asymptomatic bacteria in pregnancy to minimize the risk of it progressing to acute pyelo. And if someone does develop acute pyelo, the risk of impaired maternal and fetal outcomes, of sepsis, of preterm birth go up substantially. So it's a serious medical problem. E. coli is the most common organism, and it's important for us to be knowledgeable about antibiotic selection. This is always on the in-service exam. Culture-specific antibiotics, when you can, penicillins and cephalosporins are commonly used. These are advocated by the ACOG guidelines. Tetracycline leads to fetal dental staining. Quinolones can cause cartilage damage. Macrolides, that would be like erythromycin and azithromycin, can increase the risk of miscarriage, particularly in the first trimester. And I think you're probably familiar with the others and what the precautions are here. But even though I feel like I generally know which antibiotic to safely give during pregnancy, I virtually always check with the obstetrician and just say, is this okay for you? and I document it. I think it's important. Radiation safety, these are important principles. Obviously, keeping exposure as low as is reasonably achievable. There are extensive studies on risk to the fetus, lots of data. Less than 50 milligray is considered essentially trivial in terms of impact, but as you go up stepwise from there, it becomes more problematic. And even the low-dose radiation and very low-dose radiation CT protocols kind of get to the borderline where, you know, we have some concerns about late impact of radiation to the fetus. So it's a matter of balancing risks in terms of management options. As an adjunct to diagnosis, transvaginal ultrasound actually can be quite useful, although the number of radiologists who have experience and knowledge of it is somewhat limited. Okay, moving on to iatrogenic injury. Obviously, this is a call that we get periodically, and even though the obstetricians at a place like TCH are very skilled, considering the volume of 6,000 or 7,000 deliveries, there are a fair number of these cases that occur. In the vaginal delivery setting, we see episiotomies that lacerate into the bladder or the urethra. They usually are fairly straightforward to repair, but if they're really severe, they can be technically challenging. This area of bladder wall necrosis is more relevant in the developing country obstetrical world, where lack of access to care and very, very prolonged labor with compression of the fetal head against the pubis can cause bladder wall necrosis. And, you know, we have programs in correction of these very complicated fistulae. Baylor has a program that result when that injury occurs, but much less relevant in our practice setting in this environment. In the C-section setting, obviously, ureteral injury and bladder injury are the two calls that we would get the most often. Detection can be challenging. And the call is usually, you know, we're concerned about the ureter. Can you come and check it out and make sure we didn't injure the ureter? Now, obviously, it's easy if it's been transected and you see urine coming into the field, but in other cases, it's usually a matter of suturing in the deep pelvis or putting clips in the deep pelvis or having applied a clamp and then removing the clamp. Was the ureter injured? And you've got several choices to determine if the ureter is intact, because once you're consulted, it's your job to be correct on this. And even if you're consulted because they're concerned on the right, I would make sure the left side is okay too, because there have been notorious medical legal cases where a urologist came in, checked out the side they were requested to look at, and missed the other side. So important to be aware. But in terms of how to make sure that the ureter is okay, it's tempting to kind of start dissecting, taking out sutures, looking and digging around where the ureter might be at risk. And that can be pretty risky, you know, to have resumed bleeding, to cause an injury. If there is a way to do an intraoperative retrograde pyelogram, to slip a scope in and put a catheter or a guide wire in the ureter and just make sure with some imaging that that's safe, I personally think that's the least morbid way to answer it. The question, so at least consider that, because it can keep you out of trouble in terms of that complex dissection. Then you have the issue of whether, if there is a ureteral injury, can it be repaired at the time? And that depends on how technically demanding the repair would be and how sick the patient is. Will the patient tolerate the kind of repair that you need to do? Because there's always a damage control option for ureteral injury. You can always temporize in a really unstable, coagulopathic, hypothermic patient if there's been tremendous blood loss. Sometimes that's not the right time to do ureteral reimplantation, but you know, you can consider that as an option. And for bladder injury, obviously suturing approaches that minimize the risk of fistulization. And some of these can be rather complex. The straightforward bladder injury where there's a hole in the bladder and you sew up the bladder, generally that's a fairly straightforward repair. There's usually not too much complexity there. Dr. Sukumar, you'll recognize this case. As rare as this injury is, we actually had two at the exact same time in adjacent operating room. This is a patient who had a delivery through the bladder. So the bladder was stuck to the lower uterine segment. It was not appreciated that the splayed out bladder was stuck there. So they incised the anterior bladder wall, thinking it was peritoneum. They incised the posterior bladder wall, thinking it was the front of the uterus, and delivered the baby. In fact, what occurred was that the anterior bladder wall was open, the posterior bladder wall was open, the bladder was almost transected in a transverse plane, and the baby came out fine through the two walls of the bladder. Interestingly, I've personally dealt with about 5 of these over the last 30 years, including the 2 that we did at the same time. It's a tedious, laborious, but feasible repair. You know, we sewed up the posterior bladder wall, and we put a big Foley in. We checked the ureters, put catheters up both ureters. We sewed up the anterior bladder wall. The ureters were not transected, and in fact, in only 1 of the 5 cases that I've dealt with was there a ureteral transection. The level of the injury was at a level where the ureters were not injured, fortunately. But these are complex injuries. They will typically result in some contracture of the bladder and some loss of bladder capacity, but they can be repaired. But if you're called for this injury, you know, this is a reasonable way to approach it. Okay, let's talk about the placenta. So the definitions relate, the placenta accreta, increta, and percreta relate to the placenta having grown through the uterus and into either partially into the substance of the uterus or all the way through into an adjacent structure. And there are risk factors, and ideally this should be identified preoperatively with substantial preoperative assessment and care provided to maximize the safety of the delivery. But this requires a team, a well-organized approach, and generally, if possible, a really sort of well-planned programmatic system at the obstetrical institution. In terms of injury detection and management, obviously our general goal is prevention, but we do have to deal with injuries on a fairly common basis because of the nature of the anatomy. The Placenta Accreta Spectrum program at TCH is a multidisciplinary program with all the various medical surgery specialist teams, maternal fetal medicine, anesthesia, transfusion medicine, the neonatology, interventional radiology is generally involved as well, and us. Blood bank and transfusion medicine services have to be involved because you have to be prepared for a massive transfusion protocol. These cases should not be undertaken in a center that is not fully prepared to support a massive transfusion protocol. And I was involved in a case where I was helping with a case like this, and the hospital ran out of blood. That is not a good situation to be in. The system should have a level 4 neonatal ICU, and in fact, the system at Texas Children's now has state certification as a level 4 maternal care ICU system as well. Specialized OB intensive care is necessary, and obviously strategies to reduce blood loss, and I'll comment on those. But these are the different levels of invasion of the placenta. Accreta, meaning just basically up to the level of the inner surface of the muscular layer. Increta, meaning penetrating, and percreta all the way through the thickness of the uterine muscle and into adjacent structures. And the ones that we worry about are the ones that grow into the bladder or grow into the pelvic sidewall. The pelvic sidewall can be really scary because placenta can literally wrap around the iliac vessels and can be very difficult to deal with intraoperatively. It can occur in anywhere from about, usually most is quoted about 1 out of 1,000 pregnancies. The occurrence increases in cases where there are significant risk factors, abnormal position of the placenta, more advanced maternal age, prior uterine surgery from either fibroid removal, uterine scar, or prior C-section is probably the most common risk factor for this to occur because there's a weak spot in the uterus and the placenta can penetrate. Diagnosis ideally is with ultrasound or MRI. Most of these are asymptomatic, but occasionally they can present with pelvic pain or visible hematuria. The risk of bladder injury is about 10%. So, we're called for bladder repairs in many of these cases, although we generally always know about the case because we put up ureteral stents in all of these cases of high suspicion before the surgery occurs. And although there is some controversy as to whether the presence of ureteral stent prevents injury or reduces the risk of injury in obstetrical and gynecologic surgery, in these particular cases, they are extremely useful. And part of the reason why they're so useful is that there's a point in this procedure where you have to blindly clamp the uterine pedicle and cut above it. And if you can feel the stent and you know that that clamp is being placed 1 centimeter or 2 centimeters closer to the uterus than the stent, then you can safely make that cut, and you know you're not cutting across the ureter. So I think the ability to palpate the stent, know where the ureter is extremely helpful. And we put up stents, either the lighted stents, which are really easy to feel, or a 5 or 6 French open-ended catheter. Some of the injuries that we see with the bladder that can be challenging are when a significant portion of bladder is removed, and there are times when the invasion is full thickness into the bladder, and the obstetrician cuts out a piece of the bladder in order to get the surgery done and get the hysterectomy completed after the delivery. And if they cut out a big chunk of posterior bladder wall down close to the trigone, it can be a pretty tough reconstruction. We have had to deal with cases like that. Sometimes you have residual placenta at the margin of the injury. We have to decide whether to trim more bladder. We prefer not to. Proximity to the trigone, obviously. And sometimes the detrusor is thinned pretty well away from the actual defect, and you've got to somehow mobilize the detrusor and bring it together and try to include it in your repair. We have had a couple of cases of really severe post-op hematuria, even in cases where the mucosa of the bladder was not violated. And I think in these cases what happened was that we did a lot of suturing on the intraperitoneal surface of the bladder to deal with all these tortuous vessels that were bleeding, and probably closed off that peritoneal surface really well, and then probably developed an intramural hematoma on the bladder that then perforated through the thinned mucosa. We had a lot of gross hematuria, clot retention, had to go back to the OR for clot evacuation. So that can happen. Okay, so these are what the ultrasound images look like. And you can see that you've got placenta outside the uterus here. Here's bladder, but not much in the way of evidence of invasion. This is my colleague Karen Fox, who runs the Accreta program. And this ultrasound shows a high likelihood of invasion of the detrusor. This is placenta outside the bladder. That's the bladder. And then this vascularity here is highly suggestive of at least invasion into the more outer superficial layers of the detrusor muscle. And we see that, we're prepared to proceed and help with the repair. This is a case of a full thickness invasion of the placenta into the bladder. The bladder lumen is here, and this is full thickness invasion. This is a patient that I cystoscoped when I put the stents up, and I could see placenta just with a translucent layer of mucosa over it. And there was one area where I think it actually had perforated and then just was covered with granulation tissue, but there was no detrusor in this area, and this required a very complex bladder repair. This is the obstetricians dealing with the cervix at the end of the procedure, and then we did a complex bladder repair. So just principles of involvement here: pre-op stent insertion. I mentioned the value in being able to palpate the stent. One of the things that the team does is brings in the IR folks for placement of a femoral artery access, just in case they need to do an aortic balloon occlusion. And these are technologies that I'm personally very familiar with because we use these in the trauma setting. Reboa and the newer version, the Coburn, this can be placed through a 4 French catheter, but essentially what they'll do is they'll get femoral access at the beginning of the case so that if they get into serious bleeding, they can advance the catheter, balloon occlusion catheter into the aorta, inflate it, and essentially just temporarily stop the flow into the iliacs until the hysterectomy can be completed, and that definitely can be a life-saving maneuver. Ureteral repair, fairly straightforward, not really any different than you would do in other situations, except to be selective as to when a damage control approach is necessary and when the patient actually is too unstable to have that repair done and you need to temporize. And the bladder repair, in most cases, is not complicated unless, as I mentioned, you have one of those anatomic features that I mentioned. And I would prefer to do a really robust single-layer repair of the bladder than 2 bad layers. 2 crappy layers is not as good as one really good layer of heavy figure of 8 vicryl. And we've done pretty well with that approach. They need good catheter drainage, usually for an extended period of time. If it's a tenuous repair, we usually do the first cystogram at about 4 weeks. And we like to oversee that cystogram and make sure that it's being done at the appropriate time. So this is what an Accreta case looks like. If I gave you time to count them, there are 24 people in this operating room, including 5 dealing with the neonatology issues. There are 4 people at the head of the table providing anesthesia support. And when things go bad in these cases, you need at least 4 people on the anesthesia side of the table because you're pumping blood, you're monitoring drips. This is all the stuff that's going on with this patient during the case. And here are a couple of OB residents looking on the floor to figure out why there's blood pooling on the floor. Where is it coming from? So, these are real team efforts, and they need to be organized in that way. This is one of the bladder repairs that we did, fairly straightforward bladder repair in an accretive patient. Have you ever tried to operate in a PAPR? This is during the pandemic. So this is a PAPR. A PAPR is the power air purifying respirator that in the early time of the pandemic, we would wear them when we were dealing with an actively COVID positive patient, who this unfortunate lady was. And it's hard enough operating in a PAPR, but when you also have to wear an N95 in your loops, you kind of feel like you're in a different room. But we got the case done. Okay. So the program is very comprehensive. We have a monthly clinical case review and a planning meeting where we go over all the pending patients. We have a monthly research conference. We're currently looking at correlation between the cystoscopic findings and operative findings and risk of bladder injury. Dr. Sukumar and Dr. Netty are being very helpful with these research studies, also looking at the urodynamic impact of the emergent hysterectomy and bladder repair. How do these patients really heal? What's their urologic status? There's an annual national scientific conference in the accretive program, and then we have a patient support group, and patients are very interested in continuing to support the program because of their experience. Just to touch on some of the minimally invasive surgical capabilities, there are various ways of helping identify the ureter, identify ureteral injury. This is one approach of putting ureteral catheters up and injecting this indocyanine green that can be seen with special lighting. Because I am not a robotic surgeon, it is not unusual to be in a situation where there is not in the OB setting, in the GYN setting, where there's an injury that occurs during a robotic procedure, and I need to get one of my robotically trained colleagues to help. Otherwise, I have to open. And for those of us who are kind of in that phase of career where we're not doing robotic surgery, to convert that case into an open case is a problem. Because if the patient can wake up without another great big incision that they weren't planning on, it just sort of turns the volume down in terms of how the patient and family receive the news about the complication, and obviously would bring about a faster recovery as well. So the relevance of robotic capability to deal with iatrogenic injuries in these OB-GYN settings is really important. Just finally, to touch on medical legal issues, because of these cases having a high risk of injury, it really is worthwhile, if possible, to have a preoperative conversation with the patient and family regarding the potential need for urologic repair. And I think it's very helpful to explain to the family that there are situations where there is no choice but to open the bladder in order to get the surgery done. And if people understand it that way, they're much more accepting, I think, of when it actually occurs. Adding possible repair to consent preoperatively is valuable. Aggressively assessing a patient postoperatively when there's concern about iatrogenic injury. We have patients who come out of a C-section with gross hematuria. Most of those are just due to retraction and contusion and stretch. But some of them are due to injury, and I think it's a problem if that injury is delayed is identified after the patient goes home. They should be aggressively assessed in the hospital. Managing the post-reconstructive symptoms actively is really helpful. The patients can be very uncomfortable after a bladder repair, and they need to see the urologist and understand that you're trying to help with medications and so forth. And then being present for the cystogram and the management and making sure that we participate in the decision that it's safe to take out the catheter, I think is really valuable. And then following the patient until their symptoms normalize, I think can maintain a positive relationship and be very, very helpful with patient satisfaction. These are some of the references. We have a series of papers that we've participated in. Dr. Sukumar was on this one as well, looking at the urologic impact in these patients. It's really been a great collaboration. I've worked with obstetricians and gynecologists throughout my career. This particular team, the Accreta team, is really the best experience that I've had. They're very well trained, very technically competent, but still, these are very complex cases with a high risk of injury, and it's a very important opportunity for us to collaborate. Thank you so much for your attention.